Ladies and gentlemen, I welcome you to this webinar hosted by the International Menopause Society on Understanding Bone Densitometry. I'm today both the moderator and the first speaker. But first, we'd like to thank our sponsors. And this was sponsored by Business Healthcare by an unrestricted educational grant, which means that they had no role in the selection of topics, speakers, and they have not reviewed the content of the speakers' presentations. Without people like Business, we would not be able to host this to you for free. So we really thank them. My name, as I said, is Tobie De Villiers. I'm a former president of the International Menopause Society. I'm a gynecologist by trade, but I have a special interest in bone metabolic disease. And probably more important to this topic today, I have been the director and head of the Panorama Bone Density Center since the late 1990s. So from that day till the present day, every working day of my life, I report on several bone mineral density reports. So what is the aim of this lecture? So I would like today to influence the way in which you look at the bone density reports that you get in your practice, because this report forms an integral part of the decision tree regarding diagnosis, management, and follow-up of osteoporosis. Now, very often you'll only read the cover report, and I'll show you that today, and you don't actually read what's inside and on what the reporter actually based these recommendations. And this may lead to inappropriate clinical decisions. So the aim is really to make you look at not only the cover report, but the whole report. Everything I say is based on the positions of the International Society of Clinical Densitometry, also called the ISCD. And you can go onto their websites, and any of you who are more interested, there are very good online courses that you can see here that you can follow. And this is, for anybody with a special interest in bone, is absolutely essential. Now, we always start off with a definition. So osteoporosis is a skeletal disorder, and it's characterized by compromised bone strength that predisposes to an increased risk of fracture when you fall from own body height. Now, bone strength can be measured basically in two ways that's relevant to our conversation today. The first one is bone density, which we measure by dual X-ray absorptiometry, which I'll now call DEXA, as well as bone quality, which we can measure with the trabecular bone score, which I'll now refer to as TBS. But it's always important to remember that before the first fracture occurs, osteoporosis is a completely asymptomatic and a silent disease. When we talk about measuring bone mineral density, there are two main areas that we measure. In the central skeleton, we measure the spine and the proximal femur, but we can also measure the forearm with our central DEXA devices. And the device that we basically use as a gold standard today is the DEXA device, as you can see here. The other one shown, the computed quantitative, the QCT, is basically only used in the research setting and not in clinical routine practice. There are also some peripheral densitometry devices. I'm not going to refer to them today as they are not the gold standard and generally should not be used to base any decisions upon. So how does the DEXA actually work? And it's very easy to understand. At the bottom here, we have an X-ray source, which will create energy, which will go through a shutter and will then go through a source collimator, which would put it into either a pencil beam or fan beam. The energy then passes through the bed, and it goes through, in this case, the spine, and the energy that passes is then detected by the top collimator here, which then can change it into photons, which again changes into electrical currency. So the whole point is that you have an energy source at the bottom, and the body will attenuate that signal. And the amount of attenuation correlates with the density of either the bone or the density of the soft tissue. And for that reason, we use dual energy X-rays. So we have differential absorption, so we can see what is caused by bone alone and not by the combination of bone and soft tissue. When do we do DEXA? Well, in women, any woman older than 65 years of age should have a DEXA. And but for women, postmenopausal women younger than age of 65, it is only indicated if they have a risk factor for low bone mass, and we'll talk about that a little bit later on. Women in the menopausal transition should basically not routinely have DEXAs, but when they have clinical risk factors. And it is hardly ever necessary to do a DEXA examination in a premenopausal woman, except in very severe circumstances and mostly when fractures have occurred. So this is the cover report that goes out from my bone densitometry center in Cape Town. And you see that there's a lot of information on here. So I'd like to share with you how I came to this report and on what it is based. And for you to, every time you see a report like this, to think about where this information comes from and to actually see whether you agree or disagree with that. In the first place, just hang on one second. Okay. So what I'm just showing you here is that was the cover report, but attached to the cover report, there are 4 other pages that look something like this with some pictures on it and some figures on it. And in this, the ancillary results of the femur, which actually shows a lot of information. And don't be satisfied if your reporter only sends you the cover report. You should have access to all this data. The patient paid for that in the first place. So let's first have a look at the information given at the top of the page. We need the patient's age because bone density changes with age. We need the gender as a difference between male and female. We need the race of the patient as well, as there is a difference in, for instance, black and white women. And we should know which data reference database was used. It is advised to use a uniform Caucasian, non-race adjusted female normative databases for women of all ethnic groups. But not all centers actually follow the rules. So you should know to what your patient is measured against, especially if the report doesn't make any sense. You should also know on what machine it was done, as the different manufacturers use different machines. And it's not possible to just compare the raw data of one manufacturer to another manufacturer. There is a way of correcting for that in some of the software, but even that is second best. So your best bet is to stick to one center, one machine, and one operator, especially if you're going to use serial measurements. So here I have highlighted the main part, the results. Now we see different things here in the result. And the first thing is we have different regions, and we'll get to that. And then we have a result in grams per square centimeter, and that's called the absolute value of bone density. We have something called a T-score, and we have something called a Z-score. So let's first concentrate on which one you use, the gram per square centimeter, the T-score, or the Z-score. So for your purposes, the first one, the gram per square centimeter, will only be used when you are comparing one test to one another year or so later in follow-up. For the present moment, in terms of diagnosis, we make use of T-scores or Z-scores. Now, the T-score is used for the diagnosis in postmenopausal women, and it compares the measured value to the peak bone mineral density in a young adult and it's expressed as standard deviations. So in other words, this is the one that you'll use for your postmenopausal woman, but the T-score compares it to what it was in earlier years. The Z-score, on the other hand, is primarily used in premenopausal women and in children, but the Z-score can also be used as a comparison to the same age group. So it's hardly ever used in practice in postmenopausal women. So let's make it easier. In this particular instance, the bone mineral density was reported as 0.960 grams per square centimeters, and that correlated to a T-score of -2. So how was that determined? We see that it is 2 standard deviations. That's 1 standard deviation, 2 standard deviations between peak bone mass density, and the Z-score is the difference between what it would have been for a patient of this age here and what it actually is, and that represents half a standard deviation. So that's a Z-score of -0.5. I hope that that's easy enough. So the WHO classification of postmenopausal osteoporosis is then based on the T-scores of white Caucasian women, but it's also used in men and in all races. So the normal value is a T-score of -1 or higher. So in other words, up to -1 standard deviation below peak bone density. Then low bone mass is between -1 and -2.5. The term osteopenia has fallen out of favor, and we'd rather speak about low bone mass. And then osteoporosis on DEXA criteria only is equal to -2.5 or lower. And the word severe can be added to that, or if that is associated with a fracture. But remember, in premenopausal women and children, Z-scores, not T-scores, are preferred, and the Z-score has a different value that is normal. So it can be normal up to -2.0, and it's then defined as below the expected range for age, and a Z-score above -2 is within the expected range of age. It's not called osteoporosis, which can only be diagnosed on a combination of low bone mineral density and a history of fractures. So this is one of the most common problems I see in referrals to me, that I get a premenopausal woman or a child that's been branded osteoporosis, and that was based on a T-score, which is inappropriate. And if you just have a look at the Z-score, you see that it is within the -2.0 range, so it's in fact appropriate. So in the menopausal transition, so actually before that, you can also apply the Z-score, the T-score. But this 1994 classification has severe limitations, mostly because it was never intended as a treatment guideline, and it does not recognize that a presumptive diagnosis of osteoporosis can also be made by a low trauma, a fragility fracture, regardless of the BMD. In other words, a fall from own body height resulting in a fracture is sufficient for the diagnosis of osteoporosis, and it does not differentiate between osteoporosis and other causes of low bone mass. So which region should be used? We see we have spinal, we have femur, and we have the left forearm. So let's first see which value should be used. So the diagnosis in postmenopausal women should always be based on the lowest T-score of either the spine, which is L1 to L4, or the total hip or the femoral neck. So that would be, in 95% of cases, the lowest of any of those three. We only use the distal third of the radius if any of the other two are not interpretable, as for instance in bilateral hip replacements. And the diagnosis in children and premenopausal women also uses the lowest, but in Z scores. Now, very important, you can only report one diagnosis, as osteoporosis is a systemic disease. There's no such thing as osteoporosis at the spine and osteopenia at the hip. Report the lowest value. So in this case, it would just be a diagnosis of osteoporosis. So how is the value at the spine determined? And this is the picture that the operator will have before him or her. And as we can see here, she has to determine where to put these lines. The machines will give the edges here, but the operator will have to decide which of these is in fact L1 and which is L4. And that's not always that easy. There can also be artifacts like osteophytes, which will interfere here, which has to be taken out. So there is quite a bit of skill involved on the or required on the part of the operator to measure the right part. And this becomes very, very important in follow-up, that you actually compare apples to apples. Because unfortunately, the human anatomy is not always the same. In 83% of cases, there will be 4 or 5 lumbar vertebrae, and T12 will have where the lower ribs are attached to, and L5 will be where we have just the tips of the ischium seen. Now, but in about 7.5%, there will be 4 lumbar vertebrae, but the lowest rib on T11 or T12, in 1.9%, 6 lumbar vertebrae with lower ribs on T12 or L1, and in 7.2%, 5 lumbar vertebrae with the lowest on T11. So it needs some skill from the operator to try to differentiate which one is which one. And in this case, we can see that if we put this on here, that L1, 2, and 3 are normally U-shaped, with L4 being the X-shaped and L5 having the bow tie shape. So we need some skill in terms of the operator in doing that. So we always try to use L1 to L4 for the spine BMD measurement, and you should use all evaluable vertebrae within that range, but you should exclude vertebrae affected by structural change or artifact. You can use 3 if 4 cannot be used, and you can use 2, 3 cannot be used, but never use a single vertebrae. Just remember, you cannot have osteoporosis at L2, osteopenia at L3, etc., etc. There's only one diagnosis which can be made from L1 to whatever you do. So anatomically abnormal vertebrae may be excluded if they are clearly abnormal, and it can also be excluded if it is there is more than a 1 T-score difference between vertebrae in the question and adjacent vertebrae. So you must watch on your report very carefully on which ones the determination was determined on, so that when it is done in follow-up, that the same is used for comparison. The lateral spine is, some of the older machines use that, so that's not really appropriate. So this is the ancillary results of the spine, and you'll see here the you'll see that the T-score of L1, L2, L3, and L4, but the machine will also give you different measurements, L1 to whatever, so you can decide which one you want to use for the report. In terms of the femur, it's also a little bit confusing, as we have 2 basic regions of interest. The first one is the femur neck, and this is the femur neck here, and the operator has to be quite sure that this is in the right place, and that doesn't include some of the other bone of the hip, because that could lead to an overestimation of bone density. And the second part is then the total proximal femur, which in this case is here in red. That's a little bit easier to do, but the operator also has to see that the rotation of the hip is just correct, and that can be seen by the amount of the lesser trochanter which appears on this. And the operator also has to check that all the edges are in fact normal. So this is the type of picture that you'll get on your report, so you can see what it looks like, and you can actually determine yourself whether the operator didn't make a mistake in which area was measured. And also very important is that on your ancillary report, there will be some funny ones like the troch left and right, and also wards and left and right. Now, we don't use those individually to make a diagnosis. It is only the neck or the total femur that is used. So you see here right and left. So it may be measured at either hip. So it doesn't really matter, but we do not combine the two and take the average. Sometimes people do that in comparison, but I would not encourage that. Why do you sometimes have a discordance between your value at the hip and the spine? Well, that is fairly common because peak adult bone mass and rate of bone loss are not the same throughout the skeleton. And in postmenopausal women, the initial rate of bone loss can be greater in the cancellous bone, and that's in the spine, than in the cortical bone. So typically in the younger patient, we will see loss at the spine with a fairly normal hip. And as the patient gets older, for technical reasons of sclerosis, the spine can actually increase so that the more accurate value in the older patient will always be the hip. And some disorders may affect cortical bone mostly, and that would be hyperparathyroidism. And then beware of artifacts, which Professor Pines will talk to you about just now. So just the points of interest in the radius or the forearm, and we only look at the distal third of the radius, which is this area here. All the other ones are for research purposes. And this is measured on the non-dominant forearm as an alternative site if we can't measure the other two. And I also like to do that in cases of primary hyperparathyroidism, or when you have a patient that is just too heavy for your table, then you can do that, but it has some shortcomings. Okay, so what we've decided here was that we got to make a diagnosis. So in our case in question here, our lowest value was at the right femur neck at a t-score of minus 2.4. So this then places the patient in the low bone mass or osteopenic category, and that would then be according to our WHO organization's classification that we put here. So it falls into that area there. So in the final diagnostic, we would then say that the patient has a t-score of minus 2.4 at the hip, and this is considered osteopenic. So what is the next one then? Lateral vertebral assessment, which is also called a vertebral fracture assessment. And that is a function of the modern DEXA machine that can have a look at the vertebrae with the patient either on the side or in the supine with a rotating gantry. So what we find here is a visual diagnosis of this is what it would look like normally, and that is a very severe fracture that we find at T12, and in this case here. So you should be able to see it with the naked eye before you make the diagnosis. And this is just to show we actually use the semi-quantitative analysis of Harry Janant. Harry unfortunately passed away earlier, late in last year. But what Harry described was that a wedge fracture, and basically just concentrate on these, is when the anterior area of the is decreased by 20 to 25% of the posterior area. And in moderate fracture, that would be between 25 and 40%, and severe would be more than 40%. So by grading it like this, it also gives us a way, when we do serial DEXA, to see whether fractures actually get worse or whether they then obviously are new fractures. So that is a very important part of it. And I personally believe that you cannot interpret any DEXA report without the LVA being done, because as we'll get to it later, once you have a fragility fracture, which most vertebral fractures are, it is actually an indication for treatment irrespective of the T-score. But we have another value here. It's called the trabecular bone score, and this is an additional an indication of bone strength. Now, how does that work? TBS is an advanced imaging software provided for its use as a complement to DEXA, and it's an index related to bone microarchitecture and an independent parameter for fracture risk prediction. So this is software that's added to your machine. If your present vendor does not have it, please ask them to get hold of it. Now, to imagine the technology, it would be like hovering with a drone above a forest, and the nearer the trees are to each other, the denser the forest. That's what we find here. And the further the trees apart, the less dense it is. And that's exactly what this technique basically done. And so the less dense it is, the weaker the bone microarchitecture. So in this particular report here, we then say the next step is that the FRAX model adjusted for TBS indicates a 10-year probability of major osteoporotic fracture is 11%, and for hip fracture as 5.5%. And according to NOFSA USA, this justifies the need for bone-specific medication. So in other words, what we did here is we took the data, which I said was not a therapeutic threshold, and we tried to put it in clinical context by combining the TBS score and using it in the FRAX model, because it's not yet at a minus 2.5 where we would automatically institute therapy, and because there's not yet a fracture which would institute therapy. So what is the FRAX model? It's a calculation tool which you get on the internet, as you can see there. Every country or most countries will have their own values. You have to select your country. For instance, in South Africa, we have our own values, which you just put in there. And then you have to look at the risk factors for fracture, being a female would have a greater risk fracture. The lower the BMD, the higher the fracture, previous fracture, a parental history of fracture, smoking, glucocorticoids, rheumatoid arthritis, or secondary osteoporosis, alcohol. And then in the end, you add the femoral neck bone mineral density. So, and then this can be combined with the TBS, with the software. And the reason why that is a very good idea is that the TBS basically at the moment only looks at the spine, whereas FRAX is only dependent on the hip, the femur neck. So by combining these two, we get a much better idea of what the 10-year probability of fracture would be. In this model, which is not the case that we reported on, the major osteoporotic fracture is only 1.6 and the hip fracture is 0.1. So it's very low risk. So how do we then look at these values? In other words, which patient with low bone mass or osteopenia without a fracture should we also treat? So there are different ways of doing it, but we haven't got the time. So I'm just going to use the American NOFSA model, where they have estimated in the USA based on the estimated 10-year fracture risk for any major osteoporotic fracture of more than 20% or for hip fracture of more than 3%, treatment with bone-specific medication should be considered. The UK has a much more complex model, which you can also download from the website, but that's very specific to the UK conditions, to the cost of medication there, and the local fracture rates. So in the end, then, we say that this justifies, because there is a fracture risk for the hip in this particular case of 5.5% in the next 10 years, that you should consider treatment. And I then add the first rule out secondary causes of low bone mineral density, and the screening tests are normally done at the pathologist, and then consider treatment with bone-specific medication. I want to stress this point absolutely. Once you get low bone mineral density, if loss of bone, anything like that, you need to look at the cause. There are many secondary causes, such as, for instance, celiac disease or primary hyperparathyroidism, corticoid use, etc. And you first have to fix those problems before you go on to either a bisphosphonate or whatever you want to use further. I also then just make an additional comment that all patients should have an adequate dietary intake of 1,000 to 1,200 milligrams of elemental calcium, and it should only be added with oral supplementations if it's less than that. And we have very good models of estimating the dietary calcium, such as the International Osteoporosis Foundation's calcium calculator, which can be gotten free of charge from the web at any of the app stores. So the last bit is just about serial bone mineral testing. So you can use serial bone mineral testing to initiate treatment in a patient that's just been followed up before, or you can use it to monitor response to therapy, or you can monitor individuals in whom therapy has been stopped, such as a patient who's been on hormone replacement therapy and then stops it, or patient that's on a drug holiday after 5 years of oral bisphosphonates. But we only do this if it's likely to influence patient management, typically only 1 year apart or more once the effect is established. And also just remember, you see no change in bone mineral density without any fracture. It's not a failure of treatment. It's actually a good response to treatment. One word of caution: in glucocorticoid therapy, we can get bone loss in the first 6 months, so we do it earlier on. Well, the main thing of a follow-up report that you should look at is to compare apples with apples. So it needs to be at the same place. It needs to be the same device and manufacturer, preferably the same operator, and most important, the area of interest should be comparable. So on the machines in our unit, once we have a follow-up, the machine will automatically bring up a picture to the operator of where she did measure the spine, for instance, in the previous year, or how she measured the hip. And that should be done in exactly the same way. And otherwise, it is obviously of no use. And then the very important part: when is the change significant? So we have to remember that these machines, the precision has a problem in precision. If the same operator measures the same patient for a couple of times a day, there will be a certain variance in what she will find. So in order to be significant, a change has to be outside of that which can normally happen. And it also has to be in line with the expectation on the treatment. So at the spine in our unit, the least significant change would be 0.028 gram per centimeter at L1 to L4, or slightly more, 0.039 at the hip, as the hip changes a lot slower with the trabecular bone, with the non-trabecular bone, cortical bone at the spine, compared to trabecular bone at the spine. So you never report there's a change in bone mineral density if it's not a significant based on the least significant change. So please, if your reporter does not state and bring in the LSC, the significant change, you must speak to him or her. So this is just to show what we will see on our machine when we do a baseline and a follow-up, to make absolutely sure that it is the same area that's being used. And if we have a look at the change, we will always have a look at the least significant change, which in this case is 0.018, but here is the difference of 0.090, so this is certainly significant. On most of the machines, though, this will be done automatically for you based on the values that you fed into the machine, and all these little asterisks here actually indicates that there was a significant change more than the LSC. Another important thing is always to have a look at the LVA, as in this case, the baseline had no fractures, but in follow-up, there were definitely a severe fracture at L2. And this would be a call for either to institute therapy or to change present therapy. So we now come to the end of this part of the webinar, and my take-home message to you is that the DEXA report actually entails a lot more than the cover report. You must also consider the ancillary report on which the cover report was based before making clinical decisions, especially if what is reported there doesn't make any sense to you. Go back, have a look at yourself, or question the reporter. And all decisions regarding treatment should not be made strictly on these values. It should be made in clinical context. Thank you very much. So I now will hand over to my co-presenter today, which is Professor Amos Pines, and a longtime friend of mine from Israel. Amos was, as I, a past president of the International Menopause Society. The only thing, he's gone back on the board now, and he's again a board member for this term. Amos is a specialist physician at the Sackler Faculty of Medicine in Tel Aviv, Israel, and he was former deputy head of the Department of Medicine of the Tel Aviv Medical Center. Amos, over to you. And what Amos will do is he will talk about incidental findings on the bone densitometry.
Yeah, okay. I hope you hear me. Tobie, please tell me if you hear me.
Yes, Amos, I do hear you.
You see my slide on the screen?
I see your slide. So you
Great.
Can start and just fire away.
Thank you. Okay, so again, hello there, colleagues all around the world. And thank you for joining this webinar. For many years, I have had the opportunity to deal with bone densitometry through two opposite perspectives. On the one hand, I read between 30 and 40 bone density tests every day. These reports are sent to the healthcare providers who have to decide whether or not to treat, whether or not to investigate potential medical problems that might be the reason for low values of density. On the other hand, I also work as a family physician, as a GP, who gets the report and makes the decision. From the point of care of the primary physician, I always thought that incidental findings are important and must draw our attention. So let me start with my presentation, but first of all, I have to show you that I have no disclosures. And now a question, which is very simple. You cannot wave or put up your finger, but actually the question is, how many of you are looking not only at the densitometry report, but also at the image itself? The image itself, where I walk, looks like that. So you see the spine, you see, of course, the image of the hip, both hips, and you see some data values on the right side of the paper. So I don't know how many of you actually look at the image, but I will now talk about the image. Fellow endocrinologists always tell me that all that matters for the clinician who asks for bone densitometry is whether there is osteoporosis or not, whether to recommend on therapy or not. However, incidental findings may be important, and that's why the clinician should also look at the image itself. So as you already seen in the previous presentation, this is a normal X-ray of the spine and the femur and the hip joint. No sclerosis, the femoral joint space are clear, and you can view very easily the intervertebral spaces and also the height of the vertebra. So this is a very clear image. But the DEXA image is similar, but as you can see, it's not the same. On the right side, there is this normal X-ray of the hip, and on the left side, you see the DEXA hip. It's a normal DEXA hip joint and the normal values of density, yet you see very clearly that the image is not so accurate. It's not accurate, but it's not meant to be an X-ray or a CT scan or an MRI. Same goes for the spine. On the right side, you see the normal X-ray spine. On the left side, you see the normal bone density spine. The intervertebral spaces are not so clear, yet I believe you can see that this is normal anatomy. So here is one example. By the way, all the images that I show you, I picked during the past 2 weeks from those that I read. So here is an example. You see this image, something is wrong in the femur on the right side. It's a patient age 72, and certainly it's an abnormal finding. It doesn't say what exactly is the finding, but it needs further investigation. And the value of the densitometry itself might be within the normal range. So this is a typical incidental finding that needs further investigation. Here is another example. On the right side, it's the left femur. Again, you have some kind of a focus, some kind of a round sclerotic area. This is an oncology patient. So if it's an oncology patient, you need to be sure that you are not viewing a metastasis. Perhaps the data is in the medical file, so the physician that gets the report knows that there are bone metastases. But sometimes, if you look at the medical file, there is no mention of any bone metastases. So again, an incidental finding that needs further evaluation. And these findings, by the way, are not rare, are very common. So incidental findings may help to understand the cause of various symptoms, mainly pain, on which the patient complains. Incidental findings may also be a first clue to yet undiagnosed medical conditions. For example, on the right side, you see a normal density of the spine. On the left side, you see a scoliotic spine with arthrotic sclerotic changes. So this patient probably will complain on pain, on low back pain. And maybe this would be the first clue to understand why he has this pain. Same goes for the hip joints. So we look here at the joint space itself. So look at the head of the femur, and you see this hazy, this whitish matter. And this may point at arthrotic changes at the hip joint. Remember, people that are doing, most of the people that are doing the bone densitometries are, let's say, mid-age or elderly people. So the chance that they have arthrotic changes in their hip joint is rather high. Sometimes they will complain on some difficulties in walking or some pain, but it's not yet diagnosed. And here, maybe it's the first time that the physician gets a report that tells him, please look into the possibility that there are some changes in the hip joints. Tobie already showed you some nice images of the technique that shows fracture, but he was showing you a lateral view. Here is the regular, normal AP bone densitometry. And as you see on the left side, the same patient in 2017 had rather normal L1, and in 2021, he has sign of a fracture. This is a typical image of a vertebral fracture. Moreover, there is another example. You see here again, collapsed vertebra L1, but in this case, the patient was already treated, and the treatment included some injection of cement. So cement, of course, is visible as some whitish area. So here you have collapse with cement. And if you look at L4 or L3, the height of the vertebra is much higher than L1 because of the collapse. Another example, these are signs of operation of the spine. So you see some changes in all the vertebrae that are sclerotic, arthrotic, but there was an operation in L4, L5. Some of the bone material were cut out, so the bone density is lost, and you see a space like within the bone, the vertebra, you see some space, empty space, because bone was taken out. If we look at the hand, some endocrinologists, as already said, are using the forearm densitometry as another measure for bone density. So here you see a hand with sclerotic arthrotic synovial changes at the hand itself. It's not the radius, it's the hand. So probably some rheumatic disease, probably, that must be again investigated. What is more common is the following. First of all, you see again sclerosis, kyphoscoliosis, and sclerosis, arthrosis of the vertebra. But if you look at the upper right side, it's the upper belly, you see a focus. And this focus actually is gallbladder stones. Many times, gallbladder stones are not are asymptomatic. So again, this patient, if it's not known, you have to look into the image, see this finding, and send the patient for ultrasound to see the gallbladder. Again and again and again, you can see the same type of images, gallbladder stones. Sometimes it's really a relatively large finding. Sometimes it's a small finding. And on the right side, even if you have a cholecystectomy, usually there are signs like dots, very small dots that represent the residue of the cholecystectomy. But there are other stones in the abdomen, and these are kidney stones, renal stones. So again, two examples for some kind of a finding in the left abdomen. And since I'm also a physician, clinician, I could get into the medical file of these patients, and I saw that these are renal stones that already were diagnosed and known. So gallbladder stones, renal stones, very common. Also, in this case, you see something in the middle. So actually, it's in the area of the uterus, and this is a huge fibroid, calcified fibroid of the uterus. If you deal with oncology patients, of course, the opportunity to look at bones is also an opportunity to see whether or not there are metastases. So again, these are oncology patients with bone metastases. On the left side, it's vertebral metastasis. On the left side, it's femoral metastasis. Obesity, usually if you know the patient, if you see the patient, you know that he is obese. But first of all, on the report, you see the height and the weight of the patient, it's included. But also, if the patient is very obese, above 100 kilos, it has a significant, let's say, it might affect the results. And this is how it looks on the right side. Left side is normal densitometry. Right side, you see densitometry of a very obese patient. And last but not least, sometimes the patient has devices, some abdominal ports, stomas. Sometimes patient comes with some contrast material. So you see it because this is an X-ray and you see it. So here is an example of a device that was inserted. This is a baclofen pump in a multiple sclerosis patient. So you see the device. So again and again, I think this is my final slide. Again and again, this shows you the importance of looking at the image rather than looking only at the report. You may find new things that were still undiagnosed with the patient. So with that, I finish, and Tobie, please continue for the questions if there are any.
Thank you very much, Amos, for a very clear presentation. And we both are now going to take part in the question and answer session. So I'll start off with the ones that I think is for my section. The first one is in a slim lady, BMI smaller than 20, who's very active, how do I react to a Z-score of minus 2.5? Well, firstly, you unfortunately haven't given us the age of the patient. The Z-score, I then take it that this is a patient that is less than 50 years old, so premenopausal woman. Although the BMI, although the Z-score is minus 2.5, in terms of diagnostic threshold, it still is not enough without a fracture. Osteoporosis will only be diagnosed in a combination of that with fracture. What a minus 2.5 Z-score actually tells us, you should go see why this patient has a low Z-score. And there's a great chance with a low BMI that she may suffer from celiac disease or any other malabsorption syndrome. Because in the younger patient, it is not that often that we get idiopathic osteoporosis or low bone mineral density. There's normally a cause for that. So I would react to that Z-score by looking at a possible secondary cause that can be treated and not be treated necessarily with bone active drugs. The second one, a patient with hypothyroidism. From what age is DEXA recommended? Well, hypothyroidism is one of the lesser important problems or causes or associations with low bone mineral density. But hypothyroidism per se on its own, I would not see that as an indication for DEXA, so I'd have a look at the whole picture. So then the question, next one is, what indications are there for early testing? So I think early testing in my book is if you should do it at the start of menopause or in the transitional stage. And I would do that basically based on a personal history of the patient of a fracture or a very low bone mineral density, a very low BMI at menopause. I'm not talking about the premenopausal patient, or a family history, or any other reason that you would suspect that the patient could be at high risk of fracture. Just being menopausal per se is not regarded as an indication for a DEXA examination, especially if the patient is in any case going to get menopausal hormone therapy. The next question is about how long do you propose drug holiday should be, and when can we restart bisphosphonate therapy after the drug holiday? Well, the drug holiday was actually, the term was coined when it was realized that there may be an association between the length of alendronate therapy and atypical femur fractures. Now, the atypical femur fracture refers to a fracture that's not in the neck of the femur, but in the shaft. And it was seen to be association between that and patients who's been on bisphosphonate therapy for a long period of time. Now, I just want to put the record straight in that although there's association, we still don't actually know whether it is a causal relationship. And secondly, it should be seen that the chances of developing an atypical femur fracture is much smaller than the chances of developing a normal femur neck fracture if the patient is still at risk after 5 years of therapy. So as a general rule, after 5 years of oral therapy or 3 years of IV therapy, if the bone mineral density has not improved above the level of T-score of minus 2.5, then consider a different form of therapy such as denosumab, or if the patient suffered an incident fracture, think about anabolic therapy. So if you then have a patient that after 5 years in oral therapy has improved to a state of better than minus 2.5, then you can consider a drug holiday. There's no evidence-based reason to state how long the holiday should be, but the only thing about a holiday that's always true is that the holidays always end. So it's generally about 3 to 5 years later. You can use the follow-up bone density to do that. You can use bone turnover markers to do that, but there are no real help in terms of that. So you're going to have to use your own discretion I would not repeat the DEXA after 1 year after stopping bisphosphonate. I would do the first one 2 years afterwards, because just remember, bisphosphonates stick very, very good to bone and to the hydroxyapatite of bone, and it actually keeps on metabolizing or influencing the metabolism of bone, the bone turnover, for up to 2 to 3 years after the last dosage. The next question, do we use the lowest single measurement on a vertebral assessment or take the average L1 to L4? I want to stress this very clear. You never take a single measurement. You take L1 to L4, except if one of the vertebrae have something like cement in it, like Amos showed. You can't measure it, so you've got to take it out. So then you may take only from L1 maybe to L3 if L4 is the affected one. Or if one of the vertebrae are completely out of line with the other ones. In other words, there's normally a slow increase if you go from L1 to 2 to 3 to 4. But if there's a difference of more than 1 T-score, you have to take out that one that is outside of the range. You can measure, put the measurement then either over L1 to L4 if they all confirm, or from over 3 or over 2, but never just 1, and never the lowest, always the average. There's a next question on when should C telepeptides be measured. Now, C telepeptides refers to a form of bone turnover markers. Now, bone turnover markers are standard practice in research facilities where we would like to see the effect of a bone and what effect it has on slowing down bone turnover. The exact place of that in routine clinical practice is a lot smaller. I think it is very helpful if you are dealing with a younger patient, the younger female, with a lower than expected bone mineral density, and you would like to know, is this patient losing bone, or is this just her basic low peak bone density? And if you then do any of the bone markers or all of them, you would find that there's normal bone turnover, and that would be your answer. If there's excessive bone turnover, you have to look at the reason why it is, and very often in the younger girl, that would be either something, malabsorption syndrome, or something like celiac disease. So no, our bone turnover markers are not a routine standard in clinical practice, but it can be helpful. There's another attendee who complains that the clinic who always does the DEXA always does the forearm, and then they always find the forearm to be osteoporotic. Now, I cannot really stress this more strongly. Do not look at the forearm value if the spine and the hip is available. You only do the forearm in cases where one of them are not available. I use the example of, for instance, a patient with bilateral hip replacements. Obviously, you then cannot measure that. Or sometimes in the spine, and some of those pictures that Amos showed, because severe sclerotic changes, you just cannot use it. So then you can use the forearm. And although by definition we say then if the forearm is lower than the hip, you can use the forearm. But in clinical practice, the hip, if you have a good value on the hip, and especially in the older patient, that's far more accurate than the forearm. So I'll still go by the hip. If I do not have the hip available and an older patient with the spine, well, the spine now becomes not so trustworthy. So then I'll take into consideration the forearm. And then, as we said, the patient with primary hyperparathyroidism, there it is a very good indication, and it can be your only indication of bone loss. And it would then typically be a patient with a fairly normal value at the spine or hip, but low at the forearm. That one you have to go to, but then you obviously need to be sure of your diagnosis of primary hyperparathyroidism. And normally then if you treat it surgically, that DEXA will become normal over time. So don't do the distal third of the forearm as a routine matter, and please ask your people not to do that. So I think we have covered the when to do forearm densitometry. Just add what I previously said. Sometimes you have a patient whose weight exceeds the weight limit on the table. You're going to hurt your table if you do it more than that, and then you can use the forearm, but again, use it with discretion. Somebody asked about the AI-based densitometry to improve the results. I'm not quite sure whether you mean AI. Normally in our world is aromatase inhibitors. If a patient is on aromatase inhibitors, it is a good idea to follow up with DEXA, as it can, in cases of breast cancer where the AIs are used, be of great help to see. I hope I've answered that question and that I'm not missing the point there. How long the drug holiday should be, I think we have addressed that. Why do you specifically use the distal third of the radius for primary hyperparathyroidism? Because it just affects it easier. It is mostly cortical bone in that area, and it will be affected sooner than the hip. As you know, the spine is cortical bone, and so it is trabecular bone. So it will, primary hyperpara doesn't affect the spine till long down. Diabetes is a risk factor. Yes, diabetes certainly is, and especially diabetes type 2. So you can put that in. And that was a thank you. What are the key things to look in densitometry to see if it's well taken, and the difference in machines? Well, the operator actually, I didn't put it down there, but you actually should make a statement in it that I regard this as an accurate examination, not inhibited in any way by any technical things. We normally will put in when we take out a vertebrae or whatever, but the operator should tell you whether there's anything else. There's a question about the hip actual measurement, which is the length of the femur. That was previously used, and it still appears in some of the reports, especially of the lunar machines, but you can basically ignore that. And in cases of primary ovarian insufficiency, the fancy word for premature menopause, before attaining peak bone mass, you should unfortunately then use the T-score. And so anytime that you think that the patient is menopausal, it becomes the T-score and not the Z-score. And also you can use it in the menopausal transitional period. Would like to ask, how is the aspect in the adult on vertebral shape of a previous Sherman syndrome should be treated if low T-score? In the shape can be affected. It can be falsely elevated. So if that is affects all the affected vertebrae or more than 3, then you have to discard the value at the spine. If we have a fracture at level L2, how should we assess DEXA? Is L1 to 4 useful, or is it better to assess L3 or 4, or rather femoral neck? Well, obviously you should always also do the femoral neck and the total femur, but you can, on the machine, you can erase L2, and the machine will then give you the average of L1, L3, and L4. And you can also use L3 and L4, but it's better to ask the machine for the average of 1, 3, and 4. I can also just, on that point, with DEXA and the vertebrae, we actually meet aerial density and not volumetric density like we do on the QCT. Aerial densitometry means that if you get a fracture, the area actually becomes smaller, and that's the part below the line. So a fracture will actually falsely raise bone mineral density, and that's why it should be taken out. Okay, here's a good one by David Swan, clever man. Should one pay attention to aortic calcifications in the image? David, that's a very good observation. Yes, there are some studies to show that you can put that as an incidental finding, and the patient should be evaluated by a cardiologist for coronary arterial disease as well. Another thing which you can look for is on the femurs. In cases of pending atypical femur fracture, there can be thickening, cortical thickening, and it becomes very pronounced. So that's another of the incidental findings that you can have a look at. If the difference between L14 density score and a total spine is significant, is it recommended to get a TBS study? Jose, I do a TBS study on all the patients, and I combine that with the bone density in terms of the FRAX report, because that, as I said, it helps you getting a better result, because the TBS pertains to spine and the FRAX only pertains to hip. So it makes up for some of the deficiencies in both of them. So how's DEX interpreted in setting of scoliosis? Well, it just depends. If technically you can get the true space between them, very often you can't. But mostly in these patients, the very elderly patients, in any case, because of the sclerotic changes, it's going to be uninterpretable or falsely raised. So then I would have a look at the hip, and maybe also complement it with the forearm. When monitoring patients with low bone density, what degree of percentage change which is considered alarming? Okay, that completely depends on your unit, because the least significant change would depend on what is determined in that unit. So that should always be that. Now, anything that's more of that is a reason for concern, and you should see whether the patient now actually will need therapy if it hadn't been on it, or whether you should change therapy. So there's not a percentage of change. That will be a clinical decision. What are your thoughts about starting therapy with an anabolic agent for 12 to 18 months, then transition to a bisphosphonate in order to take advantage for more metabolically active bone to improve response? Yes, Patricia, this is absolutely a thought at the moment in bonehead circles, that especially in a patient at high risk of fracture, I'm not going to go into the exact signs of what high, but if you expect that the patient is at high risk of fracture, it's probably a good idea to start with an anabolic agent. And in most cases, you will only have access to teriparatide, and to use that for 18 months, after which you can go to one of the anti-resorbents, which will be either bisphosphonate or denosumab. There are some newer anabolic agents available at the moment in the USA. Romosozumab, fantastic drug. You can also consider that. But at the moment, the data we have is mostly about teriparatide, followed by either recidronate, which is a bisphosphonate, or by denosumab. David, do we still have, there are still some questions. I'm trying to go through as quickly as possible. Do we have still questions for the next few? Okay, David's not switching me off. So I'm continuing. Use of T-scores in premenopausal women at menopausal transition. Well, that you can do, and it's absolutely your own discretion where you think the menopausal transition is situated. That would be probably the patient from 45 experiencing changes in cycle length. What about then if there's a marked difference in T-scores between one vertebrae and the other one in limb, you should consider the worst of the whole L1 or L4. Well, I think we have done that. Spine degenerative osteoarthritis can completely invalidate the DEXA, and that's where you should rather add the forearm. Our bone turnover markers, I think we have spoken about that. When should we consider high bone density disease? Well, there are some very, very fancy metabolic disorders in which high bone density are a problem, and osteosclerosis, for instance. But I think that a discussion of that is probably not very apt at this particular time. But
Dr. De Villiers, as you are the chair of this session, timing is up to you, as well as which questions go to Professor Pines.
Okay.
So I think you are the one who goes through the questions.
Okay. So I think then Amos can answer this one. The difference between femur neck bone density and total femur is significant, is it recommended to get TBS study? Well, I think we have answered that, Amos.
Yeah.
When should you start screening in premature menopause? Amos, you can answer that one.
You already referred to that.
Oh, I think we've done that one.
Yeah, it depends on the country. First of all, you didn't mention it because some countries you are allowed to send for bone density in an earlier. It's covered by the government, so this is also maybe a consideration. But usually in a healthy woman, I don't know if you should start doing it when she enters menopause. It's not necessary in all cases, as a routine at least.
Okay, Amos, this one may be in your what is the reason for sclerotic artifact in obese people? Could you answer that?
No, it's not a sclerotic. I think it's not a sclerotic artifact. It's a technical artifact because of the radiation of the X-ray. Because Tobie, you mentioned also that the bone densitometry, if you have the right machine, is also measuring also the soft tissues. So obesity is soft tissues. So soft tissues have their impact on the value of the density. Maybe, Tobie, you are more knowledgeable about it.
Amos, I think we will just treat it as you said there. I quite agree with you. There's a question about why do we get discordance between the femur neck T-scores at the right and the left, and then that can be combined to another question, is measuring both hips superior to measuring just the non or predominant hip or just one hip? So one or two hips, and why do we get discordance?
Yeah, in the past, in some places, they were saving time, I don't know, or whatever, and they were doing only one hip. But in the case that there is a difference between the hips, and it might occur, the rule is always the value which is most significant is the lowest value. So if you have one hip, which is, let's say, osteopenic, and one hip that is osteoporotic, the osteoporotic hip is the one that you have to consider. So actually, it doesn't save time to do both hips. And if you can do it, it's better to do both of them and consider the lowest value.
Okay. Then the next one, Amos, a young patient with hypogonadotrophic hypogonadism receiving HRT. How often should she be scanned? And should you use a T-score or a Z-score? So it's hypogonadotrophic hypogonadism. And receiving HRT, how often should she be followed up with a T or a Z-score?
Yeah, the point is that I think that there are no rules for that. And something that you need to understand is that the bone turnover is not fast, it's slow. And this is why Tobie mentioned earlier that usually you have to wait at least 2 years until you repeat the test, maybe 3 years. So unless you have a situation, a clinical situation, like an oncology patient that loses bone because he gets steroids or he has some other treatments that are really damaging the bone, there is no reason to do bone density, at least wait 2 years. If they take the AI medication, as was mentioned, then the oncologists sometimes do it every year. And if the situation with hypogonadotrophic hypogonadism needs a more, let's say, frequent assessment, this is okay, that the clinician will decide. Okay. So that there are no rules for that.
There's a question by one of our board members on what is the algorithm of your choice for osteoporosis treatment. So in other words, when would you treat?
I didn't get it. What does it mean, the algorithm?
Well, he actually asked, which algorithm of choice do you use for osteoporosis treatment? Or do you use an algorithm at all, or how do you decide?
I have a very simple answer. I'm sorry. I'm not an endocrinologist. I'm not running a bone clinic. I'm a family physician. So I don't think I need to answer that. Tobie is much more experienced.
Okay, I'm just going to be absolutely very simple, because I don't necessarily look at an algorithm and I decide to treat. So the rules of thumbs is that you will treat all patients with a T-score of less than minus 2.5, unless there's a particular reason for that. You will treat all patients with a clear fragility fracture. And I will treat patients with osteopenia or low bone mineral density pending the 10-year fracture risk as determined by a combination of FRAX and TBS. And for that, I think the algorithm that I use is the simple one of NOFSA in the US of A. If there is a 10-year risk of any osteoporotic fracture exceeding 20% or hip exceeding 3%, it is worthwhile looking at bone-specific treatment. And then just the last one, so can we use, after a drug holiday, should the same drug be used that was, for instance, the same bisphosphonate? Well, it depends on how well she responded to that in the first place. But just remember, your bisphosphonates only increase bone mineral density for about 2 to 3 years. After that, it stays the same because the osteoblast also gets affected. If you are, so yes, you can, but maybe it's better to look at a different drug, something like denosumab. Denosumab will exponentially increase bone density every year. And with denosumab, you can actually treat to a target of a T-score somewhere between minus 1.5 and minus 2. But when you stop denosumab, you have to go first back to something like an intravenous bisphosphonate. Otherwise, you're going to lose bone very quickly. So I think maybe the next question was about treatment choices, which one to start with. Anti-resorptive or anabolic. So I think I've answered that one. In cases of very, very high risk, maybe first anabolic and then an anti-resorptive. And in cases of intermediate risk, I would probably look at what is available at the cost, etc. But today, our bisphosphonates remain still the mainstay of therapy, followed by denosumab and then only the bone anabolic drugs. David, I think that's it. I would like to thank Amos for his very valuable part. And in this lecture, I'd like to thank all our participants. We had about 451 at one stage. And I'd again just like to thank our sponsor for making this possible. So from my side, good afternoon, or where you are, good evening or good morning.